Hey everyone, welcome to our webinar on biostatistics for better thinking. Today we'll talk about how to spot bias in health research. And my name is Tyler Marshall. I'm the founder and CEO of Marshall Clinical Research Consulting. I'll be co-hosting this webinar today alongside our very special guest, Dr. Fernanda Talarico, who's our biostatistician, and Dr. Faris Khan, who is our clinical research professional. Hey everyone, welcome to our webinar on biostatistics for better thinking. Today we'll talk about how to spot bias in health research. And my name is Tyler Marshall. I'm the founder and CEO of Marshall Clinical Research Consulting. I'll be co-hosting this webinar today alongside our very special guest, Dr. Fernanda Talarico, who's our biostatistician, and Dr. Faris Khan, who is our clinical research professional.
Hello, everyone. I'm Fernanda, and I started my academic career in my bachelor's degree studying biomedical sciences. Then I did my master's in psychiatry genetics, where I started working more towards computational psychiatry, and then my PhD continued in that path. My PhD was focused on epidemiology and public health, studying the impact of the COVID-19 pandemic on mental health here in Alberta. And I've been working as a biostatistician since before graduating from my PhD. Faris, to
Awesome.
you.
Thank you, Fernanda. My name is Faris Khan. I started my academic career from a dental degree. I'm a dentist by primary profession. I did a master's in epidemiology and biostatistics, and that's how I started getting in the field of data analysis and healthcare research and clinical research. My background is dealing with biostatistics in clinical trials, working with different CROs and pharmaceutical industry as well. Thank you very much. Over to you, Tyler.
Yeah, thanks so much for joining us today, both of you. We're really excited to have you here. So what will you learn today as part of this webinar? Our experts here will teach you about how biostatistics can be used to help improve and refine your critical thinking skills, which is important in the health research field, medical field, pharmaceutical industry, and just general life skills as well. So we'll talk about spotting bias in research studies. We'll focus on health research and quantitative research studies today, and how to recognize errors, handle selective reporting and identify that, what that means, and look for misleading statistics and um, potentially misleading claims. We'll talk about the importance of reporting data transparently, uh, publishing and reporting even null results or negative findings, but the importance of uh, pre-registering protocols and selecting appropriate and reporting outcomes um, appropriately. We'll talk about planning ahead and pre-registering our hypotheses and protocols and asking better research questions. Good research always starts with a research question, and the more refined and concise and operationally defined those research questions are, the better the study is. So we'll talk about that a bit as well, and we'll talk about practicing ethical statistics to ensure research is credible and reproducible. So you can't really be too good at these skills. They're the foundation of all we do in research, and it's something that kind of has to be practiced over time. So I hope with this webinar, even if you have experience in biostatistics, that this is not only a good refresher, but will help even refine your skills even further. So, and if you're totally new, this will be a good entry point into statistics and critical thinking as well. So for our agenda today, we'll talk about initially why it's important to learn biostatistics. We'll talk about defining and identifying different types of bias in quantitative research. We'll talk about exploring some bias with a few case studies with our experts here. We'll do a Q&A, and then we'll talk a little bit at the end about the launch of our new research academy and upcoming biostatistics and health and medical research course. And then we'll end with some closing remarks, a quiz, and a quick survey. And we'll have a bonus case study that you can kind of do on your own. And we'll provide the results of the quiz and the case study kind of in the description in the comments below. So Okay, so to our panelists, why is learning biostatistics important for health researchers from your experience? So maybe I'll start with Fernanda as a biostatistician. What would you say to people and why is this important to learn?
Um, I think it's important because biostatistics is present from the very beginning of the study all the way towards the end. So if you want to start with a real good study where you have a defined research question, a good hypothesis, and to know the sample size that you need to for your study to detect the difference that you want to detect between groups or along the time. I think base statistics is good for that. So you set up and start with a real strong case and you good and strong project definition. And then after collecting all the data, you know how to analyze and see if the difference or your hypothesis is right or wrong. If you can just apply biostatistics throughout the study.
Yeah, definitely. That's a really good point. How about you, Ferris?
Thank you very much, Tyler. So biostats is very crucial to healthcare research. For example, we have patients coming in the clinic, and as a clinician, we see this every day. And then we have patients coming in the OPDs and the ER, and they are all generating very vital and crucial data, healthcare needs of the population. So biostats actually helps us figure out all of the patterns of diseases in a population, what interventions are needed, how can we save lives. If we take, for example, stroke, which is a very common cause of death, or cardiovascular events such as myocardial infarction or heart attacks. And with this data, we can actually make those guidelines and you can say preventive measures that are needed to save lives or help at least help prevent those deaths. This helps in decision making as well. And on the contrary, this also helps prevent diseases. So if we know, for example, COVID, the lockdowns were functioning on biostats. We needed the prevalence of the disease in a population or the incidence of it to prevent its spread and curb. So lockdowns were happening based on data, and biostats was actually helping drive healthcare research decisions. And the biggest example can be clinical trials. So vaccines for COVID, how to figure out the efficacy of those vaccines, how to figure out the safety of those vaccines. Are they safe for injecting them in human beings or not? All of this needs biostats. So in a nutshell, biostats is core to healthcare research. And without understanding data, we cannot make decisions or we cannot realize what's going on just based on the numbers itself. We need inferences. We need to analyze and interpret data. And biostats helps us do that in healthcare research. Thank you.
For sure. How about you, Fernanda?
Same advice. Take it slow, step by step, start building up the knowledge. Don't take it too much at a time. Just build up because you can never learn everything there is there to learn. There's always
Mhm.
new models coming up. So just start slow, do online courses.
Yeah. No, that's good. That's good advice. I remember when I was learning biostatistics in undergrad, it initially felt pretty intimidating. And honestly, I'm not even sure I was super interested in it until I kind of started diving more into my field, starting to learn how to ask research questions that were of interest to me. And then once I started to see the applications of biostatistics and what it can actually do and how it can, identify trends and data and test hypotheses and compare results and the effectiveness of interventions. And once I really saw the use of it, I think for me personally, that's when I became much more interested. Because yeah, the possibilities are limitless once you start learning the skills in this area, I think. So, all right, we will move on into talking a bit of our core content today, which is diving into bias. So, what is bias? So, bias can mean a few different things. So, if you look at the Oxford Dictionary, um, there are a few different definitions actually. So the first one is inclination or prejudice against a particular person or group in a way considered to be unfair. So when we hear the word bias, colloquially, we most often think about, unfair bias maybe towards a group, or prejudice, who might be a synonym against a group or people that would be considered kind of unfair. It could also mean a concentration or an interest in a particular subject area, and maybe ignoring another subject area because you're focused on one area. In statistics, the definition is more related to a systematic distortion of statistical results due to a factor not allowed for in their derivation. So it's a bit of a mouthful, but that's more of the statistical definition. And I have another definition that's, I think, a little more clear. So this research paper defined bias as any systematic error in design, conduct, or analysis of a study that results in a false conclusion. So it's a systematic error, which is not a random error. So it's something that happened in the design, conduct, or analysis that leads to an incorrect estimate of the effect or exposure from an intervention on a particular outcome. So, and unlike random error, bias does not actually average out with larger sample size. So understanding bias is, I think, pretty important for a few reasons. It exists in all research, across research designs, and can happen at any point in the study process. It's very hard to eliminate. So just because a study has bias doesn't necessarily mean that it's wrong or that it's flawed or fatally flawed. Bias can be unavoidable at times, but it can impact our ability to make causal statements about say, the effectiveness of an intervention on an outcome, or the association between variable A and variable B. We might see a link between variable A and variable B, but we're not sure if there's, confounding variable or variable C that might be relating to it, right? So we have to think about bias in order to be able to interpret causality in the world. So yeah, what do you guys think about bias? What would be something that you might add if I missed anything?
I think it's a very wholesome definition to the healthcare research context. Like, it can't be any better than this, and it pretty much covers everything that we're going to talk about later in the slides as well.
Yeah,
Yeah.
for sure. Okay, so moving on. In quantitative research, which is what we'll focus on today mostly, bias can threaten internal validity. So that's essentially assessing whether the relationship between the study variables, like variable A and variable B, or intervention and an outcome, say like ibuprofen and a headache frequency, right? Whether that relationship is likely to be true based on the study methods. So bias might also threaten external validity. So external validity is whether the findings are generalizable to other settings or populations. So if we recruit a study of all men and we're looking at the effectiveness of ibuprofen on headaches, because of our study selection there, we may not be able to generalize those results to women, or generalize it to, if it's only adults, to youth, right? Because the sample population, did not include those individuals. So that selection bias there might impact the external validity, or how generalizable the findings are to a broader population. Might also reduce reliability. So reliability is when whether results can be reproducible, essentially. So you can have results that are have high validity, but might not be reliable. So might not be able to be replicated from one study to another, right? One study might say one thing, and then if another study comes along and controls for something as part of that study that they didn't think about the first time, they might find a different result. So having reliability is a really important part of scientific research. And if results can't be reproduced, then we're can't be as certain about it. So that's why another reason we never look at one study as being a source of truth in research. We always want to look at the body of evidence in multiple papers to assess true internal validity and reliability. In qualitative research, this is called trustworthiness of data. So we're not going to dive into that today. We'll probably do a course on qualitative research at some point and look into this more in depth. But there's bias can be found in qualitative research, just like quantitative research. Quant research is not inherently better or worse than qualitative research. They just ask different questions and have different purposes, but there can be bias there as well that can impact the trustworthiness and the credibility of qualitative transcripts and the dependability of those findings. So just different terminology in qual research. All right, we'll go into some case examples of quant studies. So before we go through those, we'll talk about how to think about bias, what tools we can use. We'll talk about the risk of bias assessment tool. And as we review literature, we want to think about it in a systematic approach, right? So we want to start with the study design itself. Was the study design appropriate? Were people randomized to treatment arms? Was there a control group, right? Was the allocation concealed? So did people, were they blinded, essentially? Did they know which treatment arm they were in? Was the control group adequate? Was it, a comparable intervention and a fair comparison? In terms of study conduct, was the care delivered equally? So essentially in clinical trial, one treatment in theory should be the same as the other treatment. It's called equipoise. So that is the null hypothesis, is that treatment A is no better than treatment B. And we're trying to test of whether the intervention A is in fact different or better, but without the assumption that they're the same in each arm, then the study would be flawed. So data collection, where outcomes measured objectively and consistently using validated measures. We could have the best study in the world, randomized design, but if our outcome measures or our dependent variables are not collected using validated or sound measurements, then we don't know what the data means. It might be, if we ask somebody about their headaches, 3 months ago, and they write down numbers and they don't remember exactly, right? So that wouldn't be a very validated and sufficient approach of measuring headache frequency in that case, right? So very, very important to have a sound way to measure our study variables. Follow-up, where dropouts balance between the groups. So there can be attrition in studies. So one group, people might not follow up and provide data at 1 month follow-up or 3 months or 6 months or 1 year down the road. If people are dropping out between the groups, and you might have missing data in one group versus the other, how do we handle that? And sometimes we'll use the intent to treat analysis approach, which we'll talk about more in a more advanced lecture, but there are ways to handle that, account for dropouts between groups. In terms of analysis and reporting, were all the pre-specified outcomes reported? So it can be very problematic if a research group puts in a study protocol, goes through ethics, they say they want to look at the impact of ibuprofen on headaches, but they look at 10 different outcome variables, right? Maybe they're looking at, I don't know, headache frequency, severity, duration, like vasculature, could be looking at all kinds of things. But then if they find null results on, say, 9 out of 10, and then the one positive result, they report that and not the other ones, that can be a form of bias, right? To where they basically went on a fishing expedition to collect a bunch of variables and then only say, hey, our product works now because it worked on this one variable, but not the 10 others. And that result could actually be a null finding or a random finding. So if you test something multiple times on multiple variables, there is a chance that you could have a spurious positive result, right? So if I test any intervention on enough things, um, eventually you'll get a positive result, even if it's just by chance alone. So, am I on the right track? Anything to add to that, Faris or Fernanda?
No, I think we were going right in the flow, and we have examples to cover in the
Okay,
case section as well. Yeah.
yeah. Okay, we'll keep moving ahead then. Um, so yeah, here's the different types of bias in quantitative research. These are the main ones. There's lots of different forms of bias, and I broke it down by study phase. So there can be bias from all the way from the design phase, conduct, implementation, data collection, analysis, and reporting and dissemination. These are the main ones to learn for now. So selection bias, confounding, performance bias, detection bias, and measurement bias, attrition, and then reporting and publication bias. So selection bias is the maybe selecting one group of people and not another, and not having a random distribution in your sample population, which can lead to systematic differences between the participants and can affect that generalizability. Confounding is when an external variable might be, and maybe not a thought of variable at times, might be related to both the exposure, the intervention, and the outcome, which can distort or weaken the observed effect. So we always want to try to look for confounding in statistical analysis, really important concept to learn, and we'll dive into more in our course. Performance bias. So that can be differences in care or treatment between the groups um, for reasons other than the actual intervention being studied. So, maybe like the physicians in one arm of the trial might not be providing the same quality of care as the other one, despite that other intervention existing. So that might lead to, poor results in the initial arm not because of the new treatment, but just because the practitioners were not providing care at the same quality, right? So that has to be assessed for as well. Detection and measurement bias. So that's differences in how outcomes are measured or assessed. Attrition bias. So that's the dropouts from the study. And then reporting and publication bias. That selective reporting of outcomes or results tends to often favor the positive or significant findings. And then maybe not choosing to publish studies on papers on null results. So that can bias the body of the literature as well. So if you do a systematic review and meta-analysis, you might find that intervention works across 10 studies and we found all these positive papers. But if there was 10 other papers that had null findings and they just chose not to publish those papers, that can skew and bias your systematic review and meta-analysis. And that's simply just because people chose to not publish those papers. That can be assessed for with funnel plots and other things that we can talk about in another time, but that's a big problem in research sometimes. Risk of bias tool. The ROB2 tool is very helpful for quantitative clinical studies. So it goes through each of the domains here of selection, performance, detection, attrition, reporting, and then you can go through and rank each of these domains across a study. So you can assess whether the selection bias was low risk, or maybe there's some concerns. So like randomization was not fully described, or there's high risk, no randomization, maybe predictable sequence. Blinding, they don't mention whether blinding occurred or not, so maybe that's unclear or no blinding. Maybe there's detection bias, so the participants might have found out that they were in the study getting the intervention, and they might have a report more likely to report positive findings because of that awareness that they were in the treatment arm. Attrition, some concerns might see moderate or unclear dropout, and then outcomes not clearly reported. So this tool can be helpful for going through clinical studies, and we'll do a couple case examples and go through this, and we'll rate a few of these based on our assessments, and then we have a clinical study that you can go through on your own at the end and try yourself, and then we'll provide our results in the description. Okay, Faris, over to you for your first case example.
So let us discuss this very important case study that was performed on a previous study based on a clinical trial of a drug called rofecoxib. So what happened was the pharmaceutical company that was performing the trial did selective reporting of the results of the clinical trials, which actually misrepresented the risk and benefit profile of the drug. And the mortality findings associated with the drug rofecoxib was hidden until the investigation was performed. And in April 2001, the company's internal intention to treat analysis of pooled data from these two trials identified a significant increase in total mortality. So there was a risk of death with the drug, but the company never came up by either terminating the trial early or informing the FDA of these findings. The findings from the case study suggest that additional protections for human research participants, including new approaches for the conduct, oversight, and reporting of industry-sponsored trials, are necessary. Okay. So the company was aware of the excess in total cause mortality in the Vioxx group, which was the rofecoxib group, as compared to the placebo group, was significant. This p-value was 0.026. And they later found out there is no data safety monitoring board being formed by the pharmaceutical company. So they had no red flags when they were performing the trial. In 2003, the sponsors submitted to the FDA the intention to treat mortality data without detailed analysis or comment. So basically, they omitted reporting all of these cardiovascular events and deaths caused by the drug. This was a Kaplan-Meier curve, and we can appreciate that the rofecoxib group has a higher number of mortality compared to the placebo, which is the second line below it. And this is a classic example of reporting or publication bias, selective reporting of data, which was actually harmful in this case, and they had a multi-million-dollar litigation, and it's still a work in progress. But the good thing that came out of this was that the FDA put up stringent guidelines for performing clinical trials and reporting of data. And now we have the consort guidelines to report data in any clinical trial. According to me, this will be a high risk bias in the study. We did not have the data for the other domains such as selection bias, confounding bias, performance bias, detection, or attrition bias. But for reporting bias, since the outcomes were reported incompletely and critical data for adverse events was withheld, therefore this study is a high-risk biased study.
Yeah, this is a very egregious case here. I think this is a good example of the almost worst case scenario of what could happen if you selectively report your outcomes and not, essentially hide data. It's no surprise that there's been a major lawsuit here. This is pretty unusual, and I'm sure there's been lots of changes in the industry since then, and a lot of scrutiny goes into protocol submission or review to kind of ensure that outcomes are not selectively reported like this, and hence the clinicaltrials.gov database. And there's a lot more emphasis now on reporting your hypotheses and outcomes in advance in your protocols. So yeah, very good example and kind of yeah, really unfortunate situation there. Do you know what was the outcome of this? Did they, how much
Mhm.
money they were paid? Like, did they have to pay out quite a bit? And like, what were
So
some of the implications?
yeah, some of the implications were like since it was a multi-site trial, and the participants in the UK still are in the process of getting their uh, you can say compensations for,
Hmm.
but in the US, the participants did get the compensation right away once the trial
Gotcha.
ended. Yeah.
Very interesting. All right, and for our next case example, over to you, Fernanda.
Thank you. So I chose this paper published in JAMA Psychiatry, well-renowned journal. And this is a randomized clinical trial, an RCT, on the inflammatory exposure and depression in older adults with insomnia. So the population was 76 men, 84 women, and they were divided into two groups, one taking placebo and one with endotoxin. So, and they compared the effects between these two groups. So what I'm gonna do is show a few screenshots of the paper and go through some of the things I thought was principal for the study, and then we can go over whether this would be low risk, medium risk, or high risk based on this information I'm showing.
Perfect.
So on the methodology, specifically in the trial design and oversight, they explicitly says the design of the study, which was a double-blind, parallel design, single-site, randomized clinical trial, and they reported or they adhere to the reporting trials, the consort reporting guidelines. And they prospectively registered the study on clinicaltrials.gov. It's what Tyler was mentioning before. So even before they collected the data, they had it right there showing how they would analyze the data, how the data was going to be collected, all information on the clinical trial. On the trial procedure, they also explicitly said that two groups were stratified by insomnia and in a 1-to-1 ratio, so the same number of individuals in placebo and in the drug group. They also utilized a minimation method to account for randomization procedures, and that the randomization was performed using a computer-generated random number sequence. And that all of the participants were sent out an email, and this was sent directly to the pharmacy. Continue with the methodology of this study. They say in the participants section that after screening eligibility, interviews confirmed the presence or absence of insomnia disorder, absence of depression disorder in the last year, and absence of a circadian rhythm. And that they provided the full eligibility criteria in the supplement materials in case someone was interested. And in the sample size, they went through how sample size or power were calculated. And then the importance of that is to know the difference between groups, how many individuals in each group you need to see the difference between the groups. And then to assure statistical power, the controls are oversampled, yielding greater than 90% power. So with this sample size that they collected for each of the groups, they can see an over 90% power the effect in between the groups. And then when they describe the outcomes, they really describe the primary and the secondary outcomes. The primary outcome was a self and observer rated assessment. And these are observer rated clinical measures about depression. So they stated very clearly the outcomes over there. Based on all of what the report or the article is reporting, Oh, I'm sorry. There's also the statistical analysis, which of course I'm not going to read through this, but one important takeaway message is that the analysis were reported according to the consort statement. So they are following a guideline to report the results. And you can see how detailed the explanation of the statistical analysis is. There are 2, 3 paragraphs of statistical analysis. And then now this is my takeaway from the study. So I'm going back to the table Tyler showed before on how to report bias. And for each domain, I'm taking some notes and the risk level that I would assess. So they had strong randomization, stratification, and a blind approach. They adjusted for covariates. They had a standardized protocol to write and report the results. The scales they used to validate depression or to measure the depression was validated. I didn't show this, but in their results section, they say that there was no dropout. So all individuals that started the study ended the study. And they had a pre-registration in clinical trials. So they were very transparent in the way they were reporting and they were collecting the data. So in my opinion, this would be a low risk level of bias study.
Interesting. Thanks for sharing that, Fernanda. Yeah, I don't often see studies with solid green all the way through
I know this
like
is
this
the
too
goal.
often. So this is a good example of a well
Mhm.
conducted and well reported and written clinical trial. So yeah, great example to share. So yeah, we'll just kind of go through our recap and takeaway messages, and then you can practice a bit on your own. So bias and limitations exist in almost all research. So perfection always strived for, but almost doesn't exist, except for the paper we just saw. I wouldn't say it's perfect, but that was a really well done study. Um, so there's yeah, it's hard to totally eliminate bias, and it doesn't invalidate the results, but findings should always be taken in light of those limitations, which might weaken the conclusions and the strength of the confidence in our estimates. Um, Assessing a body of evidence is always going to be superior to assessing one study. One paper can add to the body of evidence and what we know, but research has to be replicated. And if it can't be replicated, then it's it's hard to determine in whether that study is you know actually true or not, right? So transparency matters. Clear reporting of the methods and limitations allows us to judge the credibility of the findings. So if this, you could have the best study in the world, and if it's not reported clearly, then it's hard to assess what actually happened, right? So that transparency and clear writing is very important. And critical appraisal is a skill that takes a lot of ongoing practice. So that's been sort of the foundational principle of what we've learned today is how to think about research and starting to learn about critical appraisal, which is assessing risk of bias in research. So we did a little bit of that work today and using the risk of bias tools. And yeah, it's about more about developing a habit of question evidence than it is about finding those flaws. So here's some additional resources for spotting bias in research. So the Equator Network is a really good resource that if you're doing any clinical research at all, whether it's observational research, qualitative, clinical trials, you need to know what the Equator Network is. A lot of academic journals and high impact journals are going to require you submit the reporting checklist, usually with your manuscript. It's sort of like the JAMA paper that Fernanda just talked about, where the results were reported according to the consort checklist. So the consort checklist is really important for clinical trial reporting. So you can go click the link there, explore all the different tools. There's the Strobe statement for observational research. There's qualitative checklists as well. There's quality improvement study checklists that can be really helpful to use even during the planning phase of your study, when you're just writing a protocol, it's good to go ahead and look at those checklists just to make sure that you're following the right framework, organizing your approaches, your protocol properly, and assessing for any potential risk of bias that might emerge in your own studies and getting you to think critically about your own work too. So here's a link to the Cochrane risk of bias tool for RCTs. There's the Robbins I for non-randomized studies. This is helpful as well. It's pretty labor intensive to use, but gold standard. The Quadus 2 for diagnostic accuracy studies, that's here as well. There's lots of different ones. Grading evidence, this is more important for systematic reviews and assessing the quality and confidence in the estimate of an effect of an intervention on outcomes across multiple studies. So we'll talk more about this when we do a systematic review course, meta-analysis course at some point, but this is good to know about as well. You could do an entire course on grade. It's pretty in-depth at times. Yeah, and a few checklists for qualitative research that are helpful. I don't often see too many people using these in qual studies. They're becoming more popular. These can be helpful as well. So yeah, so we're going to be offering a new course. The Foundations of Biostatistics and Health and Medical Research will be coming out early next month. Very excited about that. All three of us will be teaching and have been involved in designing this exciting course. So you'll get to learn about evidence-based biostatistical concepts, skills. We'll be using practical real-world examples from clinical and public health studies using the R software, which is free to download, by the way. Fernanda will be teaching us how to use R and kind of going through the nuts and bolts of that, which will be pretty exciting. You'll build a strong foundation for analyzing and reporting clinical studies, and Faris will be teaching us a lot about the reporting and the clinical trials section. And then, yeah, it'll be designed for students, early career researchers, and health professionals. So really anybody. But those are the three main demographics I think it'll be useful for. Totally asynchronous format. So you can complete this at your own pace. If you want to do it in 2 weeks or 1 week or take 6 months to do it, it's totally up to you. We'll have biweekly office hours as well, starting in September, that will run through the quarter for live Q&A. In the evenings, we'll record those sessions as well, and put those on the course website. And we'll go through some R examples too. So yeah, Fernanda, Faris, anything you want to add about the course?
I think it's a great course for someone looking for foundational knowledge in biostats, especially getting to use R hands-on, exciting. And of course, everything is organized for you to learn, easy, go back, watch a video, come back, ask questions. So it's a very interactive and repeatable course in terms of like you get video lectures to practice and get feedback from your instructor as well.
Yeah, for sure. There'll be group discussion boards as well, so you can interact with your peers and get feedback. There'll be quizzes at the end of each module. And yeah, you'll get a certificate as well you can add to your CV. The link is here to register for the course. You should click that. So it'll be running at $399 retail, which kind of compares with usually about $1,000 for most university courses these days. So you're gonna have three experts teaching a course at about a third of the price of the university course, and we also have even some further discounts as well. So if you can register until September 1st, you'll get 60% off. So it turns out to being around $160. And then 50% off for students, which will be ongoing even after September 1st. So undergrads, graduate students, around $200, and then early career researchers, so postdoctoral fellows, medical residents, you can get it for $239. And then we'll have a group rate as well. So any labs or organizations you want to enroll 4 or more people, we can provide that for 25% off too. So
And just to add to what Faris said, we'll start from the beginning, so from the very basics of statistics, of biostatistics, and we're going to build up the knowledge. And what we were saying before about going step by step and taking it slow. So the videos will be short so that you can just take a little bit of information at a time and build up in that knowledge. So I think that's a very formatted way to learn biostatistics.
Yeah, perfect. It's a great point. And yeah, we have a quiz you can take as well. So just click the link and a quick survey about the content. Definitely want your feedback. That helps us improve and grow as well, and informs us what we should do next time. So we'll have there's 5 or 6 questions that you can take about the content to test your knowledge, and then we have a bonus case study here. Check out this paper. Here's a link of it. The effects of long-term vitamin E supplementation on cardiovascular events and cancer, randomized controlled trial. Take a look at this paper, assess it yourself with the risk of bias tool, and then let us know in the comments what you got for your results, and then we'll post our results for the quiz and this separately in a link as well if you want to take a look. So yeah, thanks very much for coming. We'll post this on YouTube and LinkedIn. Make sure you consider following us at LinkedIn and or Facebook and Instagram. There's our website as well, and then our courses are on our new marshallresearchacademy.com page. And we also offer our consulting services here, which you can go to our website at teammarshallresearch.com. Yeah, I'd like to thank Dr. Talarico and Faris today for joining us. Very exciting lecture, and yeah, really, really appreciative of you both for coming and sharing your expertise with us today.
Thank you.
Thank you very much, Tyler. It was a pleasure.
Yeah, thanks so much. And here's our references, and hope everybody has a great evening.